And as you know, the COVID-19 vaccine is quite an issue of concern among many people. And as I said, my name is Cesarina Paul. People call me C's, you can call me C's. That's all right. And I host the virtual community dialogue. Tonight, I feature and dialogue with two medical doctors, both who hail from our town, the town of Portsmouth here in the Commonwealth of Dominica. I would like to extend a hearty welcome to Dr. Shillingford, who is already here, and I invite all of you to stay right here with us as we're going to dive straight into our discussion. So it's Dr. Gregory Vidal and Dr. Nick Shillingford. These two gentlemen have humbly accepted to join us for this very important discussion. Dr. Nick Shillingford, and you can see his name here, folks. So Dr. Nick Shillingford, he is and if I'm wrong, please correct me, he's a pediatric pathologist with subspecialty training in gastrointestinal pathology and is on staff in the Department of Pathology at Children's Hospital, Los Angeles. And he's also an assistant professor of pathology at the Keck School of Medicine of the University of South California. He is board certified in anatomic pathology and board eligible in pediatric pathology. Well, don't ask me what this means, I do not know. Gregory Vidal, he's not a stranger, as I said, to virtual community dialogue. He has been with us before. In October of last year, we looked at breast cancer and even other cancers for that matter, and had a very interesting discussion. It is one of the most viewed videos on my YouTube channel, by the way. I think people are very interested in health. Yes, we haven't hit the thousands and the millions. I'm not so popular yet, but at least on my channel, it is one of the most viewed videos. So it says a lot about the interests of people and in their health, So, yes. So Dr. Gregory Vidal is a medical oncologist at the West Cancer Center and Research Institute, where he specializes in breast cancer. He's a breast cancer researcher. He estimates that 60% of his practice involves seeing patients, 30% involves research, and 10% involves teaching as an associate professor in the Department of Hematology, Oncology at the University of Tennessee Health Science Center. His personal experience was the loss of his mother to leukemia in 1997. And that motivated him to pursue a Master of Science degree with research in hemoglobin genetics to get a better understanding of the disease that took his mother. So, of course, there is a lot more that I can possibly read to you all about them, but I'm not going down into this scientific jab. Oh, here we go. Eat, sleep, cure cancer, repeat. I like that. So that's what is on the t-shirt. Yeah. And Nettie, I see you. Thanks for that. Let's talk about vaccines for a little bit, because that's what the folks want to hear about tonight. I want to start by saying that you both have received your vaccines. I'm not sure if you got both shots, both of you. I know for sure that Greg, you got both shots. As a matter of fact,
I did get both.
Yes, I've been checking you out, so I can see 2 different days, 2 different doctors giving you 2 jabs there, right? So, Nick, how about you? Did you get yours too?
Yes, I did get both.
Okay. And can you tell us, how you felt once you got the first one maybe, and then the second, and how are you feeling today?
So
Nick, before you go, Nick, which one did you get?
I got Pfizer.
Okay.
Pfizer, okay.
Yeah.
You got Pfizer as well?
Yes.
Okay. All right.
I
So
got
tell
my
us about the Pfizer vaccine then, and its impact on both of you.
so I got my first dose on December 23rd, I believe. It was
Okay.
pretty uneventful. Didn't feel anything at all. A little bit of stiffness around the site of the injection, but nothing else. My second dose I got on January 15th.
Okay.
For the first 10 or so hours, everything was fine. I went to bed that night, and I did have to wake up at about 2 in the morning because of a little bit of stiffness around the shoulder joint area and a little bit of chills. The
Okay.
following day, I was a little bit tired, some joint discomfort, and then the following day, which was a Sunday, everything was fine again up till now. It's been a week so far,
Okay.
so I haven't had anything beyond that.
So a week you've had after a week you've had both of these.
Yes,
Had both of these, and it's a week now since you've had both of the vaccines, both of the doses, I should say. Doses. What's the term?
both shots of the same vaccine.
Okay, awesome. Easier said. Okay, what about you, Greg? Tell us about your experience.
Yeah, my experience was similar except with less side effects. My first one I did about the 18th of December, and then the second one I got about the 11th of January.
Okay.
The first one, my body felt like there was something going on. I don't know if it was mental, but it wasn't anything causing me any distress. The next day I had some pain at the site of the injection, but that
Right.
was it. The second time around, I actually did pretty well, but in anticipation of issues, because I heard, and if you look at the data,
Yes.
published data on the Pfizer vaccine, you had sort of a higher percentage or risk of chills and body aches with it. So I pre-medicated. I took some Tylenol before.
Ah.
Whether or not that made a difference or not, I felt fine.
How much before receiving the first dose that you pre-medicated yourself? How long before?
So after the first dose, I didn't take anything, and so 21 days later, I got my second, and about 30 minutes before I got my dose, I took some Tylenol.
And that was only for the second one and not the
Only for the second one, right? Oh yes, I can hear the questions. Only person on the mic now. Feel good. All right. Does vaccine protect all strains of this COVID-19 vaccine?
So actually, I just read an article about that, and it seems like both the Pfizer and the Moderna vaccines are protecting against at least the one in the UK for sure.
Yeah.
There is protection against that one.
Yeah, and I just listened to a news report where the recent data suggests that it's protective. The new strains, keep in mind, the new strains that we're talking about, those, as far as we know, make it more infectious, but doesn't cause more symptoms necessarily. However, it can cause more mortality if you have a high percentage of infection and you overwhelm the system. In other words, the more people who are likely to go to the hospital, the more likely you have people to die. And so in that way, you can have increased mortality with the new strain, but the strain itself does not cause worse symptoms than the one that's already existing.
So it's more infectious, but not necessarily more virulent.
Exactly. Let's see. So let's talk a little bit about the types of vaccines. So there are many strategies. So very early on, and I don't know if you follow history, there is, and I can't remember his name, vaccines were brought, the history is the idea of vaccines were brought to the US by a slave in Boston.
Yes.
So back in Africa, there was, is it smallpox? I can't remember what the infection was, but there was an infection that was rampaging the world. And back in Africa, it was noted that if you were to take some of the pus or the samples from that infection and give it to somebody who hadn't had the infection, they appeared to be protected. So when that slave came through and was in Boston, and that, I think it's smallpox, that was rampaging that particular area, that slave started talking about it. He spoke to one of the physicians who then advocated and started doing that, and then you had a protection. And so that's how the idea of vaccines came through. What was actually happening there is you were again inoculating people who had not previously been infected with some part of that virus, such that your body got prepared for when you get a true infection. And so that's what vaccines are. So one of the strategies for vaccination is you take a piece of that infection, virus or bacterial agent, and you let the body see it. So the body creates an antibody to that piece of the molecule. Some vaccines, you actually give live virus to folks, live non-virulent viruses to folks who have not yet seen it, so that your body creates antibody.
Live but attenuated.
Right, meaning that it is live, but it wouldn't cause you to be ill. In this particular case, with the new strategy, what we've done is, I say we, but the research community has done is, in order for COVID to infect a cell, it has this sort of sticky, almost legs on its surface that has to attach to your body cell in order to infect it. So what we've done is we have created, and each one of those little legs is made from sort of genetic material. So what you've done is you've created in a lab a small piece of genetic material that only makes those legs, and you give it to the body. And so your body then makes those legs without the virus. And because those legs are foreign to your body then creates antibodies towards those legs. So when you get a true infection where the same legs, now it carries with it the virus, the body already has the antibody to those legs and it kills the virus. And so that's the strategy with this one. When you hear the mRNA, what you're actually giving the body is the genetic material to make those little legs or little foot so that your body can then make antibodies towards it. And that's the strategy now.
So and that is particularly important, and it's dear to my heart because of one of my experiences as a physician. So with the attenuated viruses, it can become a problem if the individual's immune system is not solid. So if the patient has a weakened immune system, even that attenuated virus can become a problem and lead to an infection of the individual who receives the vaccine. So the fact that we're using the mRNA to produce a small protein, the spike protein, from that virus without producing the entire virus itself, I think is a very, very big achievement for us. I've seen a patient who actually had a live virus, developed a lymphoma for some other reason, got treated for that lymphoma, and that measles virus created havoc. What we're looking at now is something totally different, where you don't have the organism being inoculated into the body, and there is no chance at all that you're going to have that virus wake up and cause the infection within the individual.
Right. So important. So the symptoms you get when you get the infection is not when you get the vaccination is not the infection, is your body's reaction and your body's production of the antibody. So keep in mind, very, very important. when we get an infection, the fever and all of that stuff that we get, we often think it's the whatever is infected us is what causes us to have that. Most times it's actually your body's reaction to that infection agent that gives you those symptoms. The fever you get, that is sometimes the inflammatory reaction that your body is producing as a result of that infection is what gives you that reaction. In this particular case, the feverish chills that Nick talked about is not because he was getting COVID infection, but it's because his body was now making undergoing an inflammatory process, making antibodies, and that's what he was getting.
Exactly. Moy, are you back? You muted, Moy.
All right, so I suspect I may have to mute myself when you guys are talking. I'm only talk when I talk, mute my mic again because it seems
it's night
like
and day, right?
Yeah.
But I'm not hearing anything now. I'm not hearing echo now.
I'm not hearing echo now.
Okay, well, let's hope that it stays, and if it comes back, then I'm gonna have to mute myself. But I picked up on what you guys were saying there, and from my reading on this, it definitely said that there will be some basic side effects, which are some of what you all have been mentioning, the whole chills, it's for some people a little fever, and headaches, yes. And so I'm not sure if you got all the questions that the folks were asking there. So
somebody said, what is attenuated, Nick?
So you can think about it in layman's term as you having an organism that is aggressive, but you found a way to tame it down. You know, whether you use a laser beam or you hit it a shot with something, but it's no longer that bad, aggressive agent that's attacking you. It's a little more docile.
Yeah. Okay. And then somebody said for AIDS, like people with AIDS and the immune system for getting attenuated viruses, is that a risk? I guess that's what they're asking.
Yeah, you all were talking a lot about you all were talking about that, like people who are more susceptible to getting sick with COVID, people with AIDS, cancer, etc. I'm not sure that I remember what you advised. Should they receive the vaccine? Does it make it more important for them to take the vaccine than not?
Exactly.
Yes. Again, importantly, what Nick was saying earlier.
Yeah.
And what I was trying to describe, when you get the vaccine, you're not getting live virus. In this particular case, you're getting mRNA that makes a spike protein, a small piece of protein. Right. So those folks can get, anybody who has low immune system, cancer, any of these other comorbid conditions we're talking about, diabetes, hypertension, heart disease, obesity, those are the folks who are most at risk, and those are the folks we need to get. When I say at risk, meaning risk of dying if they get an infection, those are the folks that we need to start getting infection. In my business, if I am giving a patient chemotherapy, I often don't allow them to get the live virus for the reason Nick was talking before. But the vaccines that are not live, they are allowed to get them.
Okay.
So one other thing I think we need to touch on is the fact that, we have people out there who would tell you that, it's only a small percentage of people who are dying because they're looking at the big numbers. However, the mortality rate is fairly high for COVID. Even so, let's assume that it's still low, and we still don't know what is going to happen to the lungs of those people who survive 10 years from now, 20 years from now. So we're not talking mortality now, but we're talking morbidity. Are those people going to suffer the consequences of their survival from COVID in a decade from now or 2 decades from now in terms of chronic lung injury and other sequelae of the virus that could really affect their quality of life in the future?
And we've seen that now. We have patients who got COVID in the early months when it first started, who have some sequelae, as you say, meaning some symptoms related to it, who one of my nurse friends, she says she still feels like she's always tired. She don't feel like she can exert herself. And her infection was what, March of last year? So there are long-term side effects.
You mean
Uh,
you mean after she received the
no,
vaccine?
No,
she
no.
got
After
infected.
COVID?
The result of the
Yeah,
infection, long term.
Okay,
yeah.
wow.
Yeah,
Because there are some proponent out there who say, let us all just allow the virus to go. We get infected, most people will survive.
yeah.
It's not going to be a big deal. The problem, there are a few problems with that. One Nick talks about, which is the long-term side effects. The second problem is there are numbers being quoted of the mortality rate being 1%. Yes, that's low. All right. But think about it. There's 300 million people. All right. If 1% of that 300 million dies, that is still a whopping amount of people. And that's not acceptable.
In the US right now, we had 500,000. We have 400 and something thousand going. In California alone, we had about 40,000. That's a lot of people.
That,
For one,
That is
from one insult, one COVID-19.
right.
in
And
1 year.
if we think about
1 year.
in 1 year, and if we think
Yes.
about our population here, that is a lot more than us here.
Exactly.
So
That's
it
what-
is a lot of people.
That's at least 5 times our population.
Yeah.
Another interesting fact is, and if you listen to the people who follow COVID very closely, and listen to some politicians who talk about herd immunity, and for those who don't know what that means, it means that if enough people in the population, and usually we try to get about 70 to 80%, are protected, are vaccinated, then it sort of confers some protection to the few who have not been. All right. So you have to get up there in order to get protection for the few that haven't been vaccinated or infected. And there are some people who propose just let us all get infected. At least if we can get 70% infected, then we'll get herd immunity and we will protect the others. The fact is, there's never been herd immunity as a result of infection. Herd immunity has only been a phenomenon as a result of vaccination. When you vaccinate enough, like when you hear MMR mumps, and you may have measles, we vaccinated enough people that the few that didn't get vaccinated gets protected. But we've never allowed a virus to infect so much people that you can actually get true herd immunity.
And that's a good point. And I mean, going back to the possible long-term effects of COVID-19, I mean, we just think about it as people getting sick. People getting sick now, they cured, what happens after that? But I mean, we have to think about it in the broader sense. Because if COVID-19 does enough damage to the lungs of their victims so that they get, this chronic lung disease later in life, it's also going to impact our healthcare system, right? It's going to impact our workforce. It's going to impact the economy. So it's not just about an individual getting an infection, getting over it, and having his problems. It's going to affect the wider world. It's going to affect the wider community.
It is affecting
it's going to be costly for our healthcare system.
Yeah.
It's just like having a large number of your individuals in your community with diabetes. It becomes a burden to the healthcare system.
Mm-hmm.
And especially if it's working age people. So the 40, 50, 60, which are your more productive years, if you get infected and sick during those, it affects everybody. It affects the kids, the family. I mean, this is how poverty starts. It definitely impacts finances and family health going forward.
Okay. Now let me ask you guys, did you get the question from Dr. Wallace, Mervyn Wallace?
No, what was the question?
Okay, so he has a few questions actually. One of them, can you get COVID-19 infection from the vaccine? I think you may have answered that already, but you may want to reiterate. Will you need to really say that?
No, you don't get it from the vaccine. As we said, it's only the spike protein you're producing.
Right.
And it's just a small portion of the vaccine itself so that your immune system can identify something off the virus,
Right.
but it's not infectious.
Right. Now, will you need to revaccinate in 1 year? You also touched on that, said there might be the possibility for 2 years. But maybe you want to talk about that again?
So revaccinate in 1 year. So the reason the studies were conducted, and I recently heard an expert talk about Dr. Fauci talking about that, because some of the proposal right now is to delay the second vaccination in order to make sure everybody gets at least, most people get one.
Yeah.
The studies have only been conducted with 3 week and probably 4 week delay. The way immunology work, you can assume that 6 weeks, 8 weeks after your first would still give you a robust enough antibody production, immune production, but we still don't know because those have not been studied.
Yeah.
So you still want to stay within that window. We also don't know how durable. I think there was some recent data that suggests that at least 2 years, you're protected for at least 2 years once you get vaccinated, or at least have immune production. We don't know much beyond that and how long it will last. So people may need to get revaccinated.
Yeah.
Essentially, this is a work in progress.
I suppose. Similar to the flu shot, the regular flu shot that is given almost every year.
Right. So I was saying that, it's still a work in progress. I mean, this thing is evolving fast, and we just don't have all the data. As you guys know, it takes a whole lot longer, not under normal circumstances, to produce a vaccine. This is moving quickly. The other thing we need to remember too is that the vaccine is not necessarily approved.
Right.
It's a temporary, it's really an authorization, an emergency use authorization.
Right.
The third thing is that...
Doc, before you give the third one, I think these are some of the reasons that people are using to be skeptical about even accepting the vaccine in the first place. The fact that some people say, so long there is cancer, so long there is this, that, why is it we can't get a cure? And all of a sudden, in quick time, there is talk about a vaccine for something that's wiping out people in such a quick time. Like, how could you all come up with, how could the medical professionals come up with a vaccine so quickly?
I want to take that.
Yes.
Because
I knew you'd want it.
I want to take that. First of all,
so by the way, without tripping Greg, Mervyn, who is posting the questions here, I think he got the Moderna vaccine.
Okay.
So he has some experience with the other one.
So he should tell us all. I wish he would come on. We can send him the link and invite him and send him the link. He can come on and say if you'd like.
He already has the link. I may have sent the link to him.
Okay.
So yes, the deal. We feel like this vaccine came up in short period of time. Actually, the people the lady, it was a lady and maybe husband and wife couple who started, or so to speak, invented the mRNA type vaccine, have been working on that for 30 odd years. All right. They've never been able to have it break through. It was because people were skeptical about whether or not that could truly produce vaccine, because vaccines were created in one way for a long time and it's had to break that mold. And it was not until we needed to do something fast in a short period of time that they decided, let's look at that route, and it so happened to be successful. So that has been in the process for a long time. Now, one of the concerns has been the short period of time in clinical trials, such that a drug goes from 5-10 years before you can get it from start of clinical trials to approval. We've gotten this one down in less than a year. Are we cutting corners?
So I want to correct one thing though. We keep calling it approval, but it's not really approval. It's just authorization to use.
Authorization to be used in people.
Right.
The fact is, we didn't cut that much corners. We, instead of sequencing, So generally, you do a phase in clinical trial. You do an early phase trial, and that phase just tells you about safety of the trial, tolerability, trying to find a dose. Once that is done, you then go into a larger trial, recruiting more patients to look for more efficacy, still looking at safety signal. And then you do a large phase 3, which is usually comparing to either standard of care, sometimes placebo, to see if that drug is better. Then that goes to the FDA. The FDA does its review and then gives approval.
Okay.
What they've done is stack them up instead of waiting for, so you do a phase 1, very small, quickly go into a phase 2, quickly go into phase 3. Another reason why a lot of trials take a long time is recruiting. When I want to do a trial in breast cancer and I need 2,000 patients of a particular type of patients, it takes sometimes 2-3 years to recruit the number that you want. The amount of patients with COVID, you could recruit that patient in a month, 2 months, 3 months, because they are all there. And so you're able to get those results quick, fast, and then see how effective it is. There was a phase 1 done, there was a phase 3 trial done, and we looked at the data. The data was presented, and it is 95% efficacious. Keep in mind, the FDA would have been satisfied with 50% in order to approve it. All right, and we got 95%.
I think 95% is very encouraging. I think it's a good rating, if you ask me. Personally, I have issues with allergies, and so I have been saying, I don't know how this is going to work out. If I were to take the vaccine, how it's going to affect me who get allergies from so many different types of things. So, I mean, what do you say to somebody who has all these complications? I mean, I know you said it earlier about cancer and these other things, but allergies tend to be triggered by inflammation. So what can you say to somebody in my case? There are lots of people like that,
So I mean,
go ahead.
The issue with allergies here is going to be whether or not you have an allergic reaction to the components of the vaccine. So it's not the type of allergy where we're talking about somebody has an asthma attack because they inhale pollen, or somebody has an allergic reaction after they had some shrimp. So that is why both the FDA, the CDC will ask you to declare your allergies to your provider before you get the vaccine. So you have to discuss that with your physician, your primary healthcare and physician, and you have to state that to the people who are going to administer your vaccine as well. I mean, even for us, a lot of us may have some sort of allergy to some component of the vaccine that we don't even know that we have. So one of the things my hospital has been doing is asking the people who get the vaccine to hang around for about 15 minutes. Just sit there. We have physicians who are versed with intubation and that administering epinephrine and that kind of thing on standby right there to make sure that if something happens, at least they can secure your airway, which is what is going to kill you with a severe allergic reaction. So people who are very versed on intubating you, securing your airway, they're right there. We haven't had an incident so far, so that's good. But that is why we're asking people to hang around.
Nick, that practice that's standard practice. So anybody who gets the vaccine anywhere, in general, they have you wait 15 to 30 minutes before you leave the area with the health folks.
Is there any follow-up with the people who receive the vaccines? Are they able to call in or maybe someone picks up on them at some point? So
there's actually an app. They encourage you to download on your phone. Is it called the VSafe?
VSafe, that's correct.
Yeah, the VSafe app. And actually, there are people, who will contact you and see how you're doing, send you messages and stuff, little follow-up to make sure all is well.
So let me ask you, before you continue, Doc, sorry. So you said it's VSafe rather, it's SAFE?
Yes, VSAFE.
No, is this only for the US or is it international?
I think it's mainly US. It's mainly the US and the FDA collecting data, and the health, and the companies must be collecting data on how patients are behaving.
All right.
How we doing?
All right.
So,
so go ahead.
No problem. The other thing I want us to remember too is that we only seem to be hearing about Moderna and Pfizer, but there are a lot of other, there are a lot of other biomedical companies out there who are working on the vaccine as well. Johnson and Johnson, for example, is working on a vaccine that may just require one dose.
One dose, and it would need to be refrigerated. It could be at four. AstraZeneca has one.
AstraZeneca has one as well.
You have the Indians. They have. I think they have one or two different types. The Indians as well.
Just in Cuba.
China too. Cuba as well.
Wow.
Yeah.
Cuba has been very good with vaccines.
If I get Cuba has a vaccine, I feel very confident. Sorry.
If Cuba said that again?
I said if I hear Cuba has a vaccine, I feel kind of confident about them because I've seen, some of what they've been able to do in the world,
So I've gotten a lot of Cuban vaccines, of course, because when we went for school,
that's true.
My meningitis vaccine, my Hep B, all of those I got from Cuba when I came in.
All right.
I'm okay. So
that's good. Vaccines out there, and we did say that there are different ones, like I said, in Cuba, in India, England, the UK. I'm sure they have a different one, don't they?
So the UK one is the AstraZeneca University of Oxford one.
Oxford, yeah.
And that does not require
low
the
temperature,
80 degrees or the 20 degrees freezer. That's why it was believed that it would be a better one for international communities.
Yes.
Its efficacy is only about 50 to 60%, though.
Yeah.
It has a lower efficacy. Yeah.
Okay.
Yeah. So one of the advantages of that AstraZeneca virus, I predict, is that
you mean vaccine?
Vaccine. So it will be easier transported and distributed in third world countries.
Yeah,
that's correct.
Because it doesn't require the robust refrigeration that we need for both the Pfizer and the Moderna vaccines.
Mm-hmm.
So I suspect that is one of the vaccines that will make its way to Latin America, Africa, maybe even the Caribbean, and some parts of Southeast Asia.
Right. Yeah, and hopefully the Johnson and Johnson, if it requires only one vaccine, the low refrigeration, and it's more efficacious, hopefully that one can even make its way internationally too.
All right.
So it's good that there are several options out there. Clearly, we won't have all the data to determine for someone to say, well, I don't want this, I want that. It's like you go into the store and you can purchase, your choice of a bleach or your choice of a drink. It's not like that. Whatever comes to us, because we don't quite have a choice, and because we also understand that because we're third world, and there are all these big countries who have the opportunity to grasp as many of those doses as possible, then sometimes it's like take what you get kind of thing. We're hoping that we won't fall into that bracket, but there's a strong possibility that could happen to small island states like ours in the region.
Well, I'll tell you, I will tell you, in my case, I didn't have a choice either. It was just Pfizer.
Yes.
So even in the first world countries, sometimes we don't necessarily have a choice. My hospital got the Pfizer, and I couldn't say that I don't want that. I'll wait for Moderna. I don't think Moderna ever came here. My wife, on the other hand, got Moderna. I'm not sure that Pfizer was a choice for her either.
Okay.
No, but importantly, though, I get your point. The World Health Organization, that's a particular focus for them. That the wealthier countries are not buying up all of the vaccines, such that the lower income countries are not getting it, and that's a focus. I think they're trying to get vaccines slotted for low income countries.
Well, just on Sunday gone, our the Prime Minister of Dominica, Dr. Roosevelt Scarrett, he was speaking with PAHO's director, the director of the Pan American Health Organization, Dr. Carissa Etienne, who's
Dr. Etienne.
Yes.
Mm-hmm.
And they were actually addressing that same issue of, ensuring that access can be made to small island states and other parts of the Latin American area. And I was happy to hear her say that she is waiting for her. I'm surprised that she has not gotten a vaccine yet, by the way. But she said she's waiting and she's ready. Like she's just waiting for her to get vaccinated. And then, of course, the Prime Minister of Dominica also indicated that he will take the vaccine, which was a good encouragement for, I'm sure, a number of people who might have been saying, me, I'm not going to take that. Although we still have some people who say, me, I'm not going to take that. But they both lamented, of course, about the need for us to get those vaccines to our region. I think the Prime Minister was saying that maybe we will get those probably by March of 2021. And I think that's an ambitious hope. Don't you think it's an ambitious hope if he says by March?
Right.
Because I'm hearing that other places are talking about 6 months down the line, etc. So I know you don't have the timeline on that, but I'm just sharing that with you, Rennie.